Good afternoon, class. The audio feed and video feed is
Good
clear.
afternoon, sir.
Yes, sir.
Yes, sir.
Okay, we will start with the class now. If you have any questions, you can ask at the end of the session.
Okay, sir.
So today we will be talking about sterilization of and disinfection of instruments. So whenever you are given a table viva, you are giving a table viva about surgical instruments or any surgical apparatus, you will be asked about disinfection and sterilization of individual instruments. Supposingly you are given an artery forceps or hemostatic forceps, you will be asked the method of sterilization of this instrument. Supposingly you are given a catheter, you will be asked about the mode of sterilization or disinfection of that particular instrument. So in general, how will we define disinfection and sterilization? Those are two different terms, right? So I'm calling from microbiology classes. So disinfection is somewhat inferior to sterilization. So whenever we are using a surgical instrument, we are opting for an operative procedure, we are planning to go inside the abdomen or inside any body cavity, we will generally prefer that the instrument is sterilized rather than disinfected. So disinfection is either we have killed all the organisms or we have removed all the organisms that are viable, leaving behind the spores. That is whatever methods we are using for disinfection, we can kill or remove, either kill them or remove all viable organisms, that is the bacteria, fungi, viruses, except for the spores. The bacterial spores, we cannot kill them by methods of disinfection. So, and in sterilization, the advantage is that we will kill all viable organisms and as well as we will kill the spores. So, sterilization is obviously a superior mode of preparation of surgical instruments rather than disinfection. So disinfection, why do we need disinfection then? We should opt for sterilization in all cases, but if there is a poor setup, like a peripheral setup, where specific instruments for sterilization are not available, then at least we will go for disinfection of the instruments. And supposingly there is a mass casualty, or supposingly we have to do a rapid procedure, then we cannot go for sterilization because it takes longer time. So we will do disinfection of the instruments and then we will go for the procedure. So generally disinfection is short, sterilization will take long time, sterilization will take better equipments, disinfection will take cheap and inexpensive instruments. So in a peripheral setup, if we have to do rapid surgeries like 3-4 surgeries at short intervals, if there are mass casualties, then we will go for disinfection of the instruments rather than sterilization. But if we are planning for a routine procedure, like we have time, we have prepared properly, then we will go for sterilization. And in general surgery, most of the operations should be done, almost all the operations should be done by sterilized equipments and instruments rather than disinfection. So, coming to different methods of disinfection and sterilization, both for disinfection and for sterilization, we can use either physical agents or chemical agents, right? Two methods, physical and chemical. Physical is generally will give heat, and chemicals will use different type of chemicals. And in physical, different types of radiation also comes, alpha radiation, gamma radiation. So that is also a physical method of sterilization. So physical and chemical methods of sterilization as well as disinfection. Physical is generally heat and radiation, and chemical is generally using chemical solutions and gases. So coming to physical means, so it is either it is heat. Heat again is of two types, either dry heat or moist heat, right? Dry heat and moist heat. Dry heat are again of mostly three types that we use in our setup. That is flaming of the instrument, incineration, and hot air oven. So flaming of the instrument, you might have seen like whenever supposing we are using a flame of a Bunsen burner. We are using the flame of a Bunsen burner, and we will take a needle or other metal instruments and we will pass through the Bunsen burner, or we will hold it over the Bunsen flame of the Bunsen burner till it becomes red hot. So again, flaming is of two different types: longer time and shorter time. Longer time is when we hold the instrument over the Bunsen burner flame and wait till it becomes red hot, and then we remove it, cool it down, and then use for operation. And other is just we have put it for a shorter time. We will not wait till it has become red hot. For example, glass items, we will not wait till it becomes red hot. Metal items, we can wait till it becomes red hot. So that is flaming. Another method of dry heat is incineration. Generally, dead bodies, other organic matter, supposedly infected sputum, infected biological matter, all those are incinerated. And then the third is that is used in our OT or operative setup is hot air ovens. Hot air ovens will use dry heat with a fan so that it becomes circulated. There will be an apparatus and we will circulate the dry heat. So generally, those are used in Department of Microbiology, hot air ovens. Hot air ovens are used for glass articles like petri discs, pipettes that are used for titrating urine and other biological products. So pipettes, petri dishes, and glass beakers, then jars, test tubes, all those are sterilized by means of dry heat. And by dry heat, we can also sterilize liquid paraffin and certain other products like fat and other solutions like glycerol. So generally, in terms of dry heat, we'll talk about flaming, incineration, and hot air ovens. And now we will talk about moist heat. Again, moist heat is again of three types: below 100 degrees Celsius, at 100 degrees Celsius, and above 100 degrees Celsius. So below 100 degrees Celsius, we will not talk about. Generally, it includes pasteurization, water baths, and all those. But are not used in surgical instruments. So that is below 100 degrees Celsius. So generally, surgical instruments, moist heat we will use at 100 degrees Celsius or above 100 degrees Celsius. At 100 degrees Celsius, we can boil the instruments. You have seen when you have visited the outdoor or the OT, there are certain water baths that are used for boiling. So we can boil the instrument. So generally boiling, we cannot raise the temperature above 100 degrees Celsius. So boiling is at 100 degrees Celsius at atmospheric pressure, and generally if you do it for 15 minutes, then we will consider it as disinfection. If we do it for half an hour or more, then we can consider it near sterilization, but it is not foolproof sterilization. That is, by boiling, we cannot be sure that we have killed all the spores. So generally boiling we will consider as a method of disinfection. 15 minutes, boiling for 15 minutes at 100 degrees Celsius at atmospheric pressure, it is disinfection. If we go for 30 minutes or more, near sterilization, but 100% sterilization we are not sure about. So boiling is generally used for surgical instruments widely. Then we can use for steaming, like moist heat, we can use a steamer. It will be a closed chamber and perforated tray will be there. We'll keep the instruments and we'll steam it. So generally, Koch or Arnold's steamer are used. Generally, Koch steamer or Arnold steamer are used. So surgical instruments, moist heat, we will boil, or that is at 100 degrees Celsius. And if we go above 100 degrees Celsius, it is autoclave. So moist heat, below 100 degrees Celsius, at 100 degrees Celsius, and above 100 degrees Celsius. Moist heat below 100 degrees Celsius, generally a good example is pasteurization of milk and other products, right? Not used for surgical instruments generally. Then at 100 degrees Celsius, boiling. Above 100 degrees Celsius, autoclave. So this is the at 100 degrees Celsius, above 100 degrees Celsius, many categories of things will be included, but in terms of surgical instruments, we will remember just boiling and autoclave. Below 100 degrees Celsius, we will not opt for. So autoclave is the preferred method. So it is moist heat above 100 degrees Celsius. So autoclave is same like the pressure cooker that you use every day in your kitchen, right? So at atmospheric pressure, the boiling point of water is 100 degrees Celsius. So if you increase the pressure, supposing in a closed compartment you have put pressure and you have boiled the water, so the temperature of boiling will go up. So that is the basic principle. So more heat will be generated inside in a pressure compartment. So that is the concept of autoclaving. So autoclaving is generally like a big pressure cooker where we have put the instruments, we have put water, and we have generated heat inside, moist heat inside. So generally autoclave, the standard autoclave protocol is 121 degrees Celsius, and the pressure inserted is measured in pounds. It's 15 pound per square inch. 15 pound per square inch for 15 minutes, right? So that is standard autoclave. 121 degrees Celsius, 15 elms or 15 pounds per square inch, 15 minutes. So that is the standard that is followed in general surgical setup. Supposingly, you know that all the bed sheets, other instruments from a big hospital setup like ours, it goes to a central sterilization unit. So in that central sterilization unit, what they will do, they have big, very big, like water tank size, big autoclaves. So there they will put all the instruments, benches, other things that needs to be autoclaved, and they will autoclave instantaneously. So they will they do not have 15 minutes to autoclave it. They will autoclave it for a shorter duration. So to attain the same efficacy by reducing the time, what do? We increase the pressure. So as we increase the pressure, the temperature for boiling of water also goes up. So for in a short time, we can do the process fast if we increase the pressure and increase the temperature as well. So generally in central autoclave system, in OT we will follow 121 degrees Celsius, 15 hours, 15 minutes. But in a central autoclaving unit, supposingly in the central unit, so we will follow generally 133, 134 degrees Celsius, and we will do it for 3 minutes, and the pressure will be increased to 30 pounds. So that is used in a central system. So it is fast and as well as similarly effective like the process that we do in our OT setup. So that is autoclaving. So generally we will the physical methods we have covered. Again, another physical method is gamma ray irradiation. Gamma irradiation is not practiced in a small setup. So gamma irradiation is generally, it is factory grade sterilization. That is factories where mass production of instruments are there, mass production of other plastic items or catheters, sterile things are produced. They will do a gamma sterilization. Okay, so that is gamma sterilization. So we have covered the physical methods. To recap, generally we will use boiling or autoclave. Those are the basic things that are used. Again, now coming to the chemical part, the physical part is over. Now coming to the chemical aspect of sterilization as well as disinfection. You have seen, right? The most basic chemical that is used is spirit, right? So we will use generally, what is it called? It is called the surgical spirit. What is surgical spirit? Actually, it is 17% strength, mainly ethanol. So it is 70% ethanol. Surgical spirit that we use for draping of the patient or for sanitizing our hands in surgical OT, or sometimes for sterilization of disinfection of instruments also. That is, surgical spirit is basically 70% ethyl alcohol. Generally, two types of alcohols are used, ethyl and isopropyl. Basically available is ethyl alcohol. Isopropyl alcohol is also available. So by alcohol disinfection, generally spores are not killed. So we will consider it as a level of disinfection only by cleaning the instruments with alcohol or dipping the instrument in alcohol for a certain amount of time. So generally we will keep it for 12 hours for proper disinfection or sterilization, means tending towards sterilization, disinfection. So that is about alcohol. So alcohol is generally suboptimal for like proper instrument sterilization. So the things that we will use for sterilization or other sterilization chemicals are aldehydes. Aldehydes are basically two aldehydes that we use, formaldehyde and glutaraldehyde. You have come across formalin in your anatomy department or other departments. So we will use formaldehyde. So what is formalin? Formalin is basically 40% aldehyde, formaldehyde. Generally, before using formaldehyde, we will dissolve it in water. So that is 40% formaldehyde is formalin. So when you are asked what is formalin, it's 40% formaldehyde in water. We can use it in alcohol also. We can mix it and use it in alcohol also. So formaldehyde sterilization or formalin sterilization can be used, but the drawback is that it is very irritant. It gives fumes, so it is irritant to your eyes. It can cause chemical pneumonitis. So if you inhale it, it is toxic. It is irritant, as well as when you put the metal instruments, it is corrosive to the instruments also. So formaldehyde or formalin, generally formalin we will use for whenever we do a surgery for preservation of the surgical specimen, for histopathology analysis, we will use formalin, and we will use formalin for as a whole sterilization, disinfection of the whole OT, whole operation theater room. So we will use formalin vapors or formalin gas to sterilize the OT. We will close down the OT, and either we can use a hot method or other methods. So we will put formalin at the center of the OT, and then we will leave it for a day. So that is how we sterilize the whole operation theater room. Generally, it is not used for instruments. So that is about formalin or formaldehyde. Then stepping down from formaldehyde is glutaraldehyde. That is less toxic, less irritant, less corrosive. So glutaraldehyde we will use for surgical instruments. Formaldehyde will not use for surgical instruments. Glutaraldehyde is less toxic, less irritant, and less corrosive than formaldehyde. Yes. So we will use glutaraldehyde. Glutaraldehyde generally we will use in strength of 2%. So that glutaraldehyde solution will be greenish in color, green color solution, 2%. Generally the speaking term for glutaraldehyde is Sidex. We will say we are using 2% Sidex. 2% Sidex is nothing but 2% glutaraldehyde. So it is a green color solution. It will be whenever we talk about glutaraldehyde, we should say as freshly prepared 2% glutaraldehyde or 2% Sidex. What is freshly prepared? Generally, the solution that we buy from the market is inactive. We have to alkalinize the solution to activate it. When we alkalinize it, it will become active only for 14 days. After 14 days, it is no good for use. So after 14 days, we will discard it. So we were talking about chemical methods of chemical sterilization and disinfection. So mainly three products: alcohol, aldehyde, and phenol and phenolics. So we have talked about alcohol. 70% alcohol is surgical spirit. Generally, we will assist disinfection by it. Then we have talked about aldehydes, formaldehyde and glutaraldehyde. So glutaraldehyde is 2% Sidex. Generally, it is used for 14 days. And how do we sterilize the instruments with glutaraldehyde? We will dip the instrument in glutaraldehyde, completely immersed, and we will keep it for 20 minutes. So 20 minutes we will assist disinfection. If we go for 4 hours, or in some books it says 12 hours. So if we go for 4 hours, so we will achieve near about sterilization. So 2% Sidex, if we keep it for 20 minutes, it is disinfection. 4 hours, it is sterilized. So what we do is generally we have started the operative procedure early in the morning, so we get a long time. So initially at the start of the OT, what we do is we will dip it in Sidex or the surgical instruments for 4 hours. So we have assist sterilization. Then from shifting from one case to the other, I have done the first case, I have operated the first case, then I am going to operate the second case. There is not much of a gap, right? So then we can keep it for 20 minutes. So we have disinfected the instrument and then we can use it. Generally, that is not the standard or the best way to do it, but can be done. So early in the morning, 4 hours sterilization. Then in between cases, we can do a 20-minute disinfection. So that is about glutaraldehyde. Now we come to phenolic compounds. So phenolic compounds, phenol and phenolic compounds are derivatives of phenol, right? So you know phenol, that is used as a household product for disinfection and wiping the floor and all. So phenol is somewhat toxic and irritant. So generally phenol, as such, phenol is not used. Generally we will use other phenolics. Other phenolics means they are derivatives of phenol. So phenol is derived from basically coal tar. We know coal tar. If we distill coal tar to fractional distillation, then we get phenol and phenolic compounds. So again, we will not use phenol as such, but we will use other products similar to phenol. Those are known as phenolics. So in our surgical setup, we will use phenolics. So phenolics are Crile, Lysol. We have heard Crile, Lysol, Dettol, all those stuff, right? So and chlorhexidine, all those are phenol and phenolic compounds. So generally in our setup, we will use Lysol in two forms, either concentrated or dilute form. Generally, if we use a concentrated form of phenol, we can put the instrument for 1 hour, it is sterilized. If we use dilute form, we have to keep it for 12 hours, that is overnight or more for proper sterilization. So generally in our setup, in surgical setup, we will use a very thick, viscid, concentrated Lysol, where you will see all the sharp instruments like scissors and knives, blades, all those kept there for 1 hour. So generally we will use Lysol in surgical setup for sterilization. 1 hour dip in concentrated Lysol for 1 hour, we will assist sterilization. So and generally we will not use the phenolic compounds in skin. So skin generally we use spirit or iodine compounds like betadine, right? So betadine is generally it is asked in exam 1 is betadine. Betadine is an iodine compound. It is PVP iodine. Betadine is PVP iodine. What is PVP? It is polyvinyl pyrrolidone. PVP iodine. So it is a non-toxic form of iodine, and generally that form of iodine, it does not develop resistance for the organisms. If we repeatedly use certain disinfectants or certain products to kill organisms might require some sort of resistance, right? But it has been seen that iodine and iodine products, and specifically PVP iodine or polyvinyl pyrrolidone iodine, which is actually betadine. So generally organisms do not develop resistance against that. So that is used in the skin because it is not toxic and it is not a skin irritant. Phenolic compounds, they are toxic and some amount less toxic and less irritant. So generally they are not used directly on the skin. They will be used on the floor or surgical instruments only. So now coming to a different type of phenolic, which is Crile, Lysol, all those we will not use directly on the skin or mucosa or directly on the body. But there is a type of phenolic known as chlorhexidine, right? So we can use it in the skin directly, or Dettol, right? You know, it is chlorxylidone. So Dettol and chlorhexidine, that is chlorxylidone and chlorhexidine. Generally Dettol, the active compound is chlorxylidone. So that is Dettol. So Dettol and chlorhexidine, we can use it on the mucosa. You know, right? Hexidine mouthwash we use. The basic component of hexidine mouthwash is chlorhexidine. So those phenolics are not toxic, so they can be used on the body directly. And so you know what is the active ingredient of Dettol? It is chlorxylenol, and of Savlon. Active ingredient of Savlon is chlorhexidine. Savlon is a combination of chlorhexidine and citramide. So Savlon is chlorhexidine plus citramide, and Dettol is a composition of some phenolics, but the active ingredient is chlorxylenol. So other compounds we can use iodine, as I have told you. So basically, these are the agents that we will use in surgery, as well as we have discussed in last class ethylene oxide, right? So ethylene oxide is a gas, so we will need a gas chamber. In that chamber, we will put the instruments, and then we will release ethylene oxide, and we will sterilize the instruments or whatever apparatus. So ethylene oxide can penetrate through plastic and other rubber materials. So those surgical instruments and apparatus like certain tubes, Rile's tube, and Foley's catheter, and drains, certain tube drains or flat drains, they can be sterilized by means of ethylene oxide. It is also a industrial mode of sterilization. So gamma radiation ethylene oxide generally industrial grade, large scale sterilization we can do. So generally some of the packaged things like the disposable syringes, Rile's tube, and Foley's catheter, all those, as well as surgical drains, they will come in ethylene oxide, sterilized, pre-sterilized, sealed pack. So you have to turn the pack whenever it is given to you and ask what is the method of sterilization. You have to flip the packet and see. It will be written as EO sterilized. So it means ethylene oxide sterilized. Whenever the examiner asks, you have to see and answer him that it is ethylene oxide sterilized or pre-sterilized. So basically, sharp instruments, surgical instruments, they will be metal, right? And optical instruments like endoscopes, all those optical instruments, generally we will sterilize. It's a general rule of thumb. So mainly the instruments we will categorize into three: metal instruments, sharp and not sharp. The not sharp instruments and sharp metal instruments like scissors. So the not sharp metal instruments will autoclave it straight away. So it is sterilized. And the sharp instruments, if we autoclave it, it will lose its sharpness. And then the metal will get oxidized and there will be a crust formation, right? So that is not a preferred method. So sharp surgical instruments we will not autoclave. Blunt surgical instruments made of metal we will autoclave. Even rubber also we can autoclave. Supposing rubber gloves, surgical drains, those are open. Other rubber instruments we can autoclave, as well as blunt metal surgical instruments we can autoclave. But the temperature will be different. The duration of autoclaving will be different. Surgical instruments we can autoclave for a longer duration, but rubber we will do it at half the duration. So blunt metal surgical instruments we will autoclave. Rubber surgical instruments we will autoclave. Sharp metal surgical instruments we will dip it in concentrated Lysol for 1 hour. And then you know, right, the phenolic compounds, they are irritants to the skin. So before using it in the patient for an operative procedure, we have to properly rinse it in sterile, normal saline, right, or distilled water or whatever is available, sterile. So we will rinse off the Lysol and then we will use the sharp instruments for operation. And then coming to optical instruments like fiber optics that are used, like the endoscopes, cystoscopes, laryngoscopes, all those optical laryngoscopes. So all those will be dipped in 2% Sidex or 2% glutaraldehyde solution, freshly prepared 2% glutaraldehyde solution for a duration of 20 minutes. So basically, autoclave, Lysol, 2% glutaraldehyde. That's all for most of the surgical instruments, and ethylene oxide or gamma radiation for factory sealed instruments. So now we will talk about surgical instruments. So we have done, finished sterilization. So now we'll talk about the surgical instruments. So you can see the slide that is projected on your screen. So basically a surgical instrument will have 5 parts. So any basic surgical instrument we will have 5 parts. The part that we use to hold the instrument is called finger bows, or finger rings, or finger bows, BOWS. So these are the finger bows. So that is used to hold the instrument. Then after that we will have a shaft or body. So this is the shaft. Anything proximal to the joint and towards the finger bone, this is the shaft or the body. So there will be a pair of shafts, right? So there will be a pair of shafts, then there will be a joint, and anything beyond the joint is the blade of the instrument. It is not necessarily a sharp, it may not be a sharp, the limbs may not be sharp, but still we will call it a blade, right? Even if the limbs distal to the joint are blunt, we will still call it the blade of the instrument. So finger bows, then comes the shaft or the body, a pair of shafts or body, then a joint, and then the blades. And in some instruments, there will be a ratchet or a catch or a clutch that we use, right? So this part which I am showing just above the finger bones is the ratchet or the catch or the clutch of the instrument. So there will be generally 3 or 4 grooves made here. So whenever we press the instrument and the ratchet or the clutch or the catch is closed, so the instrument will maintain that position. That is the closed position. The instrument will maintain the closed position even if we do not put any effort, or if we do not put any force. So basic parts of the instrument are finger bows, ratchet or catch, then shaft or body, then joint, and the blades. So today we will talk about most basic instrument and widely used instrument in surgery, hemostatic forceps, right? So whenever we talk about hemostatic forceps, the main purpose is hemostatic, right? So to hold bleeders or blood vessels to achieve hemostasis. So generally in colloquial terms or like saying terms, we will say as artery forceps. But the actual name is, so whenever the examiner asks you not after artery forceps, you tell it as hemostatic forceps. Generally, in terms of size, 3 types of hemostatic forceps, like large, medium, and small. So, and in terms of the curvature, there will be 2 types, right? Straight hemostatic artery forceps are straight, and curved are curved. So the one that are above are straight, and the one that is on the right side are curved. So straight and curved hemostatic forceps, size will be large, medium, small, and there are different types. Actually, basically speaking, 3 or 4 types of hemostatic forceps that we use in surgical practice. The most commonly widely used is Spencer Wells. Spencer Wells hemostatic forceps. So generally we will use Spencer Wells or Kelly's. So most of the hemostatic forceps available in our setup is Spencer Wells hemostatic forceps or Kelly's. So how will you differentiate Spencer Wells and Kelly's? So Spencer Wells hemostatic forceps, the minor differences are like the blade will be, this is the blade part, right? So if you consider this as a Spencer-Wells hemostatic forceps, so the blade, the main difference between the Spencer-Wells and Kelly's hemostatic forceps is the serrations made in the blade. So this is the blade part. So distal to the joint, this is the blade part. So this blade part in any hemostatic forceps will have transverse serrations. That is, the serrations or there will be grooves made that will be transverse. In case of Spencer-Wells hemostatic forceps, these transverse serrations will be present all along the blade. But in case of Kelly's, it will be present only on the distal part. That is, on the proximal part of the blade, the transverse serrations will not be there. It will be present only on the distal part of the blade. So basic difference between a Spencer-Wells and Kelly's is short, right? So the way to remember it is the name is short, the serrations are also short distance, and Spencer-Wells, the name is long, so the serrations will be also long. That's all along the blade. So that is a basic difference between Spencer-Wells and Kelly's forceps. And other differences are generally in case of Kelly's forceps, always as compared to the shaft, the blades will be shorter. Generally, in case of Spencer-Wells, it will be half. It will be half the size. That is, in compared to the shaft, the blade will be half the size. But in case of Kelly's, it will be somewhat longer than Spencer-Wells. The blades will be longer. Both versions are available, a straight or a curved. So, basic difference between Spencer-Wells and Kelly's is the transverse serrations. Kelly's partially serrated, that is not serrated in the entire part of the blade, and Spencer-Wells serrated all throughout the blade. So that is the basic difference between Spencer-Wells and Kelly's. Another type of forceps is Edson's forceps. Edson's forceps is generally fine. Edson's forceps is the shaft. As compared to the shaft, the body will be smaller. Body will be smaller, shorter. So that is Edson's forceps. Generally, whenever you pick up a forceps, you need to differentiate basically whether it is a Spencer-Wells or Kelly's. Spencer-Wells is full serrated. Kelly's is not full serrated. We cannot say it as half serrated also, but it is not serrated all throughout the length. So that is the basic difference between Spencer-Wells and Kelly's. Other types, Edson's you may be given, but it is okay if you do not differentiate it as Edson's specifically. In Edson's forceps also, same like Kelly's, the serrations will not be present all throughout. In Edson's forceps also, serrations will be present in some part, in less part of the blade only. Spencer-Wells full serration, Kelly's Edson's less than full serration. Then so you can see here that a Mosquito hemostatic forceps is mentioned. What is a Mosquito hemostatic forceps? Same like an artery forceps, but this big hemostatic forceps. But the size will be very small. The instrument will be very delicate. Generally, Mosquito hemostatic forceps is a smaller version of hemostatic forceps that is used for pediatric surgeries and for delicate surgeries, right? For cleft lip surgeries and used in infants and kids and pediatric surgery. So how will we sterilize the instrument? Again, we will autoclave the instrument, right? As we have talked earlier. Then, what are the uses of hemostatic forceps? Basic use, the number one use is to achieve hemostasis. As soon as we proceed with a surgery, we reach below the dermis, there will be bleeders, like bleeding vessels. So as soon as we reach below the dermis, we will see blood vessels that are oozing or bleeding. So we will catch those with these hemostatic forceps and we will secure hemostasis. Other uses are we can use to hold certain structures with the artery forceps, like basically tough structures and aponeurosis, like the external oblique aponeurosis, we can hold it with the hemostatic forceps and oppose it and help in closure. And we can hold the linea alba also, we can hold the rectus seat, all those tough structures, we can hold it with hemostatic forceps. In appendectomy, hemostatic forceps have great role, right? Well, we will use a straight or a curved hemostatic forceps in appendectomy to split the muscles. So whenever we are splitting the muscles, we do not want to cut the muscles, we will split the fibers of the muscles, we will use a hemostatic forceps in appendectomy. Again, in appendectomy, to cross the appendix before ligating, earlier, it was an old practice, we used to cross the base of the stump, then we used to ligate the stump. So to cross the base of the appendix, we used to use a hemostatic forceps. Again, for blunt dissections, supposedly in a lipoma, in a sebaceous cyst, if you want to dissect just below the skin and subcutaneous fat and above the lipoma or above the lump, so we will do that dissection with a hemostatic forceps. Those are the uses of hemostatic forceps for blunt dissections, for achieving hemostasis in appendectomy, to split the muscles, to hold tough structures like aponeurosis and muscle sheaths. And another use is we will use a medium or large size hemostatic forceps for dressing, as a dressing forceps. We will hold swab or gauze with the forceps, and they will use for dressing. So that is basic about hemostatic forceps. Then another hemostatic forceps is a Kocher's hemostatic forceps. It is quite different from other hemostatic forceps in that the most identifying point of Kocher's hemostatic forceps is it will have a tooth, a single tooth on one end of the blade, and on the other end there will be a groove. So when we close the forceps, the tooth will oppose with the groove, and it will be a tight seal, right? And the transverse serrations, we need to remember, it will be present all throughout the blade. So transverse serrations all throughout the blade, as well as a single tooth in one blade and a groove on the other blade. So that is a Kocher's hemostatic forceps. Other normal hemostatic forceps like Spencer Wells, Kelly's, Adson's, Mosquito, they will not have this tooth and grooves assembly. So if we see a tooth and a groove assembly at the end of the blade, we are sure that it is Kocher's hemostatic forceps. Generally, Kocher's hemostatic forceps is a stout instrument. Artery forceps like Kelly's, Adson's, all those will be delicate or like thin instruments, but this, as compared to that, Kocher's hemostatic forceps will be a stout and tough instrument. So the blade will be longer and wider in Kocher's hemostatic forceps. Again, either variety might be present, straight variety, curved variety, and size also large, medium, small might be available. So we can achieve hemostasis with a Spencer Wells hemostatic forceps also. We can achieve hemostasis with a Kocher's hemostatic forceps also. So why do we need an extra assembly of tooth and groove? So why do we need this extra sharp part? So generally there are certain blood vessels while doing OT, it will, as we cut it, it will go inside the tissue, or it will be inside a tough structure, it will go inside an aponeurosis. So to hold those vessels that have a tendency to retract, we will use these instruments. So any artery or any vessel that has a tendency to retract and go inside or under the structure, we will generally use this Kocher's hemostatic forceps. So there is a history behind the development of this hemostatic forceps. As you know the name Kocher, right? So it was developed by Emil Theodor Kocher. So Emil Theodor Kocher, he invented this instrument or developed this instrument. So it is named after him, Kocher's hemostatic forceps. He has a great role to play in thyroid surgeries. So So generally, while doing a thyroid surgery, there is a vessel, so which you will come across, middle thyroid vein. So it is a very short vein, less space to manipulate, and it opens directly into a very important vessel, that is the internal jugulars, right and left. So he developed this instrument to hold that artery as well as to hold the thyroid. It is a very vascular structure. So while operating, it bleeds to hold the isthmus. While doing a partial thyroidectomy, he developed this instrument to hold the middle thyroid vein. While doing a thyroid surgery, he developed this instrument. So these vessels, they have a tendency to retract. Again, other vessels like in the scalp, like in the breast, the perforating vessels in the breast, so they have a tendency to retract. So for holding those instruments, we will use the Kocher's hemostatic forceps. So the perforating vessels in the breast, thyroid surgeries to while doing a partial thyroidectomy, while doing while holding the middle thyroid vein, and while holding other task structures, we get the help of this assembly. It is a very tough structure, and it needs great force to pull it together and suture it. So we can use this instrument, supposedly to hold the scalp, to hold other task structures like a meniscus, middle meniscus, lateral meniscus, right, in orthopedic surgeries. So to hold those, or even we can hold the linea alba with this. But we remember that this is a traumatic forceps, right? Very traumatic. So there will be tissue damage. Some amount of tissue damage will be there. So retractile vessels task structures, we will use the Kocher's hemostatic forceps. Again, method of sterilization is same. We will autoclave it. Okay, so we will wrap up the class here. Rest of the instruments we will discuss later. So anyone has any questions can come forward. So if anyone has any doubt regarding the topic we discussed today, okay, so we will wrap up the class here. But before wrapping up, again, we do not need to confuse with sterilization and disinfection. Generally, most of the surgical instruments we will go for autoclave, metal instruments as well as rubber instruments. Sharp instruments we will keep it in Lysol, and laparoscopic instruments like fiber optic cystoscopes, laparoscopes, those have a glass assembly inside. We will leave it in 2% Sidex or 2% glutaraldehyde solution. So that's all. Those three means for most of the surgical instruments. Okay, so we will wrap up and thank you for attending the class.